A very good afternoon, everyone. We are back again, and this time the session is mega revision targeting FMG. So, if the audio visual is working well, you can see me, you can hear me, please give me a thumbs up as a reassurance. Okay, so hi Rishi Raj. Well, I would just want a confirmation before I start the session. If everything is working well, please give a reassurance. Okay, perfect. So basically, this session is approximately 1 hour and 20 minutes, and we're targeting FMG, and we're going to have a mega revision for ophthalmology. The date is out, the preparation is on its peak. Now there is no time to rest, right? So make your schedules, follow them strictly, discipline yourself is the way to go for it, right? So with all this, I'll start. Okay. So this is a 24 years old boy with history of wearing glasses of -8 diopter sphere, both eyes, presents to the OPD for a routine evaluation. All of the following may be seen. Hi Amrita, hi KK. Well, there's an emoji there which I cannot interpret. Anyways, if all is well, you can just write down if I'm audible, I'm visible. Just write all right, and or you mention it in a clear way so that it confirms me for the same. Okay, so now here this was what we were discussing. A 24 years old boy with history of wearing glasses of -8 diopter sphere presents to the OPD for a routine evaluation. All of the following may be seen except. So the options that we have are a supertraction crescent, lacquer cracks, Foster Fuchs spots, and small disc. So now you tell me what is the answer. All right, so Amrita says answer is D. So you mean to say the correct answer for this option is D. All right, any other takes for this? Anybody else who differs with this? Right, see, the thing is now the examiner has very smartly asked you what does the examiner wants to know. When he says -8 diopter sphere, what is he talking about? What is he talking about when he talk of -8 diopter sphere? We're talking about pathological myopia, or what is called as high myopia. And what is the value when we say it is high myopia? We call it as high myopia when it is more than -6 diopter sphere. That is classically when you call it as high myopia. Okay, so now all he wants to know is what does the examiner wants to know from you? The examiner basically wants to know what are the fundus findings of high myopia. It is just to simplify this question, right? So the basic aim is that you should be able to interpret what the examiner wants to know from you. All right, so let's see. Now the option A says supertraction crescent. Okay, if we consider the changes like this, so when we talk of changes of pathological myopia, when we talk of changes in pathological myopia, we'll divide them into two types, right? One are the disc changes. There are the disc changes. And the other thing that we see are the changes in the retinal fundus or retinal changes. Okay, so we'll classify the changes in the pathological myopia under these two categories. So let's see what are the disc changes first. So when we talk of the disc changes, they are what you see here basically is, if you see here, this is the disc. So it is a tilted disc, but normally what you get in such patients is a large disc. There is a large disc. Number two, there is a temporal traction crescent. By that I mean, so you understand the disc is of a larger size, temporal traction crescent, by that I mean, so basically what happens is pathological myopia is because of the increased growth of the eyeball. So when the eyeball is growing, there is posterior staphyloma, the globe as a whole is stretching, so there's a stretch at the level of the retina also. So what happens is the retina is kind of pulled away. The retina is kind of pulled away from the disc margin. And when this happens temporally, this is the temporal side. How do you know this is the temporal side? Here is the fovea. This is the fovea, right? So when the disc, when the retina here is pulled away temporally, that is exactly what you call it as a temporal traction crescent. So once there is a pull here towards this side, on the nasal side, there is certain amount of the tissue which overrides the disc, and that is called as nasal supertraction crescent. Right? So what is temporal traction crescent or temporal traction here, which is seen? If you see, so this is the temporal traction crescent. Here, basically, the retina is pulled away from the temporal side of the optic disc. Okay, and nasally, similarly, it overrides the optic disc, which is called as the nasal supertraction crescent. So you have a larger disc, there's a temporal crescent, there's a nasal supertraction crescent, and last but not the least, there is a peripapillary atrophy. There is a peripapillary atrophy. By that we mean that all around the disc there is thinning, so there is a peripapillary. Peripapillary means around the disc there is an atrophy. So these are the changes, disc changes in pathological myopia. So what are the retinal changes in these patients? Let's see. If we start naming them, let's see. So what do you get to see here? If you see here, what is it? Anybody wants to attempt? What is this that you get to see here? What is it? This is a hole. So there is a peripheral retinal hole. Then what is this? What is this? Anyone who wants to attempt? What is this? This is a lattice degeneration. Then we come to image C. What are these? So here also in image C, you can see this is the traction crescent. Right? So basically the retina is kind of pulled away from the temporal side of the optic disc, which is exposing the choroid and the sclera underneath, right? So what is this thing here? These are the Foster Fuchs spots. So what are these Foster Fuchs spots? Foster Fuchs spots are nothing but these are the areas of RPE hyperplasia, which are occurring secondary to some choroidal neovascularization or a hemorrhage. So overlying RPE undergoes hyperplasia. So you can have Foster Fuchs spots. Then what do you get to see in this image? D. This is A, where you have a hole. This is B, where you have a lattice degeneration. C has the Foster Fuchs spots. What is D? So it is here. See, this is the retinal tear with retinal detachment. We all know myopes are exposed, or myopes have a high predisposition to retinal detachment. Then what do you have it here? Similarly, you have a hole here also, the one that you got in image A. But what the difference here is, this is at the macula. So what do you call it? We call it as a macular hole. We call it a macular hole, right? Similarly, now what is this? This is again at the macula. So at the macula, you can get a choroidal neovascular membrane, which is called as myopic CNVMs. So what do you have? You have myopic CNVM. And what are the other changes? So the other retinal changes are, what you get is posterior staphyloma. So what is posterior staphyloma? It is a localized bulge which happens at the posterior pole. So what are the other retinal findings in myopes is posterior staphyloma, right? Then you can have is lacquer cracks. What are lacquer cracks? These are basically the breaks which occur at the level of Bruch's membrane, right? Choriocapillaris complex. Okay, so you can have lacquer cracks. What are the other things that you can have? You can have a PVD. So when a PVD occurs, you see a ring-like structure in the vitreous cavity. Anybody wants to make an attempt? What do we call that? When the PVD occurs at the level of the disc. So from the disc margins, there is a posterior vitreous detachment. What is that called? Anybody wants to attempt? What do you call that? So posterior vitreous detachment means the vitreous detaches from the posterior part of the retina, and once it comes off the disc, it is in a ring-shaped structure at the level of the vitreous. So what happens is there is a ring-shaped PVD at the level of the vitreous, and what is it called? It is called as, anybody wants to attempt? It is called as V's ring. It is called as V's ring. Last but not the least, what we get is a tigroid or a tessellated fundus. And to complete the list, we have chorioretinal atrophy. So this is the complete list of the fundus changes that you find in high myopes or in pathological myopia. So this is beautifully described under two headings. One are the disc changes and the other is the retinal changes. So disc changes, you have a larger disc, temporal traction crescent, nasal super traction crescent. Super traction is because there is RPE and retinal overriding onto the disc nasally, right? So what you have to take care, this happens nasally, and temporal is the traction crescent, and there is a peripapillary atrophy. Whereas when you talk of the fundus changes, retinal changes, what we have is we can get a hole, we can have a tear, and both of these can result in retinal detachment. There will be lattice degeneration like this. So what do you see? Then the periphery, you see these white crisscross lines. There can be a hole at the level of the macula, which is called as the macular hole. There will be Foster Fuchs spots, which are the areas of RPE hyperplasia. And there can be CNVM at the level of macula, which is macular CNVM. Then you have posterior staphyloma. Staphyloma is a localized bulging which you get posteriorly at the level at the retina. You can have lacquer cracks. This is again something which is important. Lacquer cracks is something which is very, very important. You should remember what are lacquer cracks. PVD here, it is called as the V's ring. It is called as the V's ring that occurs at the level of the optic disc, tessellated fundus, and chorioretinal atrophy. So coming back to the question, now you all know why the answer is D. Is that clear? Okay, so super traction crescent, we do get lacquer cracks, we do get Foster Fuchs spots. So what is the answer? The answer is small disc. And if this is incorrect, what should be the correct answer? The correct answer instead of small disc would be that we have just discussed, it is a large disc. Okay, all right. So now we move on to the next one. So identify the correct combination of the stain which is used along with the filter. So this was a question in this year NEET PG. So please remember, when you're sitting for FMG this year, you should be done, properly revised, and should not make mistakes on the previous year question, especially the ones which have come recently in the NEET, the last FMG, INI-CET. At least the questions would not be repeated same to same, but what is repeated are the topics. So you should be clear with your topics. Do not miss on those topics. I again repeat, it is the repetition of the topics. So you might hold the ear like this, or you might hold the ear like this. It is the same thing. But the thing is that topic will have more than one questions or more questions from the same topic. So that should not be the mistake. Okay. All right. So identify the correct combination of the stain used along with the filter. I want the answers. So everybody says fluorescein with cobalt filter. Very good. And now my second question is, what is the percentage of fluorescein that is used? Tell me. Anybody wants to make an attempt? What is the percentage of fluorescein that is used? So now here, even in such questions, even if you do not know the answer, let's see how do you make a best guess. So basically in this image, if you see, there are errors which occur on the side of the examiner also. We have seen that occurring in this year, the last INI-CET, right? So there was this all picture with all the labels also. So that might also happen. So when such things happen, use them to your own benefit. So you should be smart enough to catch those marks, to catch those points, and just bounce on them. So even if you do not know, what you get to see in the background is a blue color. So if we see a blue color, that means there's a filter which is being used as a blue filter or a blue light filter. So which out of these is a blue light filter? We know it is not red. So they obviously, we struck out that. So this is gone, this is gone. So now we are left with two. And whenever you're left with just two options, always attempt. There is a 50% probability of making it correct. Even if it is a blind attempt, always attempt. Whenever you come down to two options, always attempt. Okay? Forget percent. All right. So basically, when you talk of this answer, so here what is seen is green. There's a green stain which is seen here, which is under the blue light. So what is a green stain? So whenever we're in doubt in fluorescein, so what is the mnemonic that you should always remember? The mnemonic is OBG. So whenever we talk of a fluorescein dye, the thing that we should remember is this. So let's see. So when we talk of the fluorescein dye, how do you remember? Remember the word OBG. What do you mean by that? By that we mean fluorescein is an orange colored dye. It is an orange colored dye which is irradiated with blue color. Blue color. Hence, what is used is cobalt filter, and this is of a lower wavelength. This is of a lower wavelength and it emits green color. Okay, it emits green color, which is now of a higher wavelength. Which is of the higher wavelength. So orange colored dye irradiated by the blue light, which is the cobalt filter, and emits green color, that is of the higher wavelength, is the fluorescein dye. What is the derivative of fluorescein that is also used in the ophthalmology? So now we have a derivative of fluorescein, which is the derivative of fluorescein is, which is the derivative, which dye is it? It is the rose Bengal dye. So rose Bengal dye is basically the derivative of fluorescein and it is very toxic, right? So the other thing also that you have to remember is, now what is fluorescein used for? The fluorescein basically we use in a concentration of 2% fluorescein to stain, and it stains what? What all does it stain? It stains cornea as well as conjunctiva. And fluorescein is one of the most commonly used vital stain. It is the most commonly used vital stain, right? So it is used to stain cornea as well as conjunctiva, right? And it stains what? It stains all the ones that lack the basement membrane. So cornea as well as conjunctiva. So this is the fluorescein dye. So if we come back to the question now, tell me what is the answer? Everybody says A. Yes, absolutely. That is the correct answer. It is A, which is it is a fluorescein which is used with a cobalt filter. So blue light emitting the green light, fluorescein dye, which is used to stain cornea as well as conjunctiva. So you will have epithelial aberrations, you will have ulcers as well as conjunctival for the assessment of dry eye, for assessment of TBUT, for the assessment of all the punctate keratitis. We all use fluorescein dye. Okay, all right. So now we move on to the next one, which is this. Again, this is a repeat question from the NEET PG this year. So refraction through what kind of a surface? And you get this. What is this called? Tell me, what is this called? What is this called? Anybody wants to attempt? What do you call it? So there's a hint here. What do we call it? Conoid. Okay. I got an answer called conoid. So, what is the full form? What is the full term? What is the full name? It is called as conoid of Sturm or Sturm's conoid. It is called a conoid of Sturm or Sturm's conoid. So, what is Sturm's conoid? Now, you have to tell me it occurs through what kind of a surface? Is it myopic, hypermetropic, astigmatic, spherocylindrical, or toric? Tell me what is the answer. Tell me. So, what is the answer? Anybody wants to attempt? So, basically, what is Sturm's conoid? Now, you just get through. Sturm's conoid is basically the it's a orientation or it's a presentation of the rays which are converging through a toric surface. It's not myopic. It's through a toric surface or a spherocylindrical surface or an astigmatic surface. So whenever you kind of study the way the rays pass through the toric surface, through the spherocylindrical surface, or through the astigmatic surface, we call it as Sturm's conoid, right? So let's see. So the answer here is basically C, D, and E because the three mean the same. It is the toric surface, the spherocylindrical surface, or the astigmatic surface. Now, coming to this, I will tell you. So, basically, when we talk of conoid of Sturm, right? So, this is basically the orientation of rays passing through a toric surface, an astigmatic surface, or a spherocylindrical lens. By that, what do we mean? So here, if you look here, so basically when we talk of toric surface, we have two meridia, one is vertical and one is horizontal. So these two meridia have different foci. So that means one, if it is more myopic, will converge the rays quicker as compared to the other meridian, right? For example, here, the vertical rays which are coming are converging before the horizontal ones, right? So there are two focal points of a toric surface. So how the rays pass through it? So if you take a section through here, you say the vertical rays are converging and the horizontal are also converging, but not as much as the more myopic surface, which is the vertical here. So what you get here is this is converging more as compared to horizontal. Hence, this is a horizontal oval. But then you come to a point where the vertical principal meridian just converges. Once it converges, so what you have is there is nothing which is vertical, but the horizontal rays are still passing, hence there is a horizontal line. Then what happens after this point, once the vertical meridian has converged, it starts to diverge, but the horizontal ones are still converging. So there comes a point where the amount of deviation is equal to the amount of convergence, right? And that is called the circle of least diffusion. So here it is converging and here it is deviating. So once this amount of deviation is equal to the amount of convergence is what you call as the circle of least diffusion. Then the one which is less myopic will kind of converge later, which is giving you a vertical line. So this is Sturm's conoid. Also, if you want to know about the surface, the Sturm's conoid in detail, I have taken a special free class. There is a special free class which is available, on the platform under refractive errors. Right? So you must go through this. So this is a free special class which is there on the Unacademy platform, and this is concerning all the refractive errors, where these terms conoid is discussed in detail. So you can go and listen to that lecture also. That's a 1 hour session and you must attend that, right? So this is what you get. Now don't forget, so this is the Sturm's conoid or conoid of Sturm, which is basically talking about the orientation of the rays which are converging through a toric surface, an astigmatic surface, or a spherocylindrical surface. Well, Anjum, I would tell you that this is a mix what I have got through for your revision of all those topics which are mostly anticipated, which have come. I'm basically, as I told in the beginning of the session also, it's just not the similar question, but it is covering those important topics. So I am covering all the one important topics that have been asked in the past or that are anticipated to be coming this year. Okay. All right. So then we come to the next one. Now, you have to match the following. Let's see. So it is A, B, C, D on one side, and on the other side, we have picture 1, we have picture 2, picture 3, and picture 4. Right? Anjum, I hope that answers your question. Okay, so which out of these you have to tell me matches to mature cataract? Okay, I think you're unable to see picture 4. I will move a bit so that you can see. All right, so that is better now. Okay, so now tell me mature cataract matches with which picture? Well, Anjum, I tell you one thing. Anything related to science, anything, any information, everything is volatile unless and until we all keep revising, right? So it is, yes, it is that, but what I would say is there is no shortcut to success. So keep revising, keep listening, keep revising your notes. That is the only thing. All right. So I've got the answers, and everybody says picture 3. Well, I would say I tend to differ. Please see the picture behind me. Please see the picture behind me. Consider this one also. So if you talk to me about mature cataract, out of these 4 pictures is mature cataract? Anybody wants to make the difference? Okay. So the answer here basically is picture number 4. This here is the mature cataract. So when we talk of the mature cataract, we talk of a pearly white nucleus. We talk of a pearly white nucleus, which is seen in image number 4. All right. Then we talk of hypermature sclerotic cataract. Now, what is the answer? Okay, now tell me. For option B, hypermature sclerotic cataract, which number is it? Okay, I've got the answer 111. Okay. Well, I would say when I talk of hypermature, you missed an important word here. The word of importance here is sclerotic. The sclerotic cataract. So when we talk of a hypermature sclerotic cataract, okay, let's see. So when I talk of hypermature sclerotic cataract, please pay attention to here. So when we talk of sclerotic cataract, what are you going to see? What you will have is a convoluted surface, or what you call it as a corrugated surface with calcific deposits. Right? So coming back to this, any image now, anybody who would like to change. So hypermature sclerotic is once there is degenerative changes after mature cataract. So all the liquefied cortex, it tends to start going out, and then the surface becomes corrugated with calcium deposits. Now, do you want to change the answer? So which out of these four is the hypermature sclerotic cataract? So the answer here is picture number 3. Do you get that? Why? Because if you try to see this picture, so what you have is, now see carefully, what you have here is, see here, these are the corrugated surface. See, what you have is a corrugated surface. And you see here, what are these? These are the calcific deposits. Okay, so now you get it. So this is, and this B matches to picture number 3. Then we come to posterior subcapsular cataract, which is called as the PSC, or the posterior subcapsular cataract. So now we're just left with 2 images, image 1 and image 2. Which out of these 2 is posterior subcapsular cataract? C, you say, is 2. Absolutely right. So C is, you're right, C is 2. So when we talk of posterior subcapsular cataracts, the problem with these cataracts is the patients complain of glare. The patients complain of glare. And what is image D? 1 is this. So picture 1 is Morgagnian cataract. So when we talk of Morgagnian cataract, what do we get? When we talk of Morgagnian cataract, please note. So what you have is a liquefied cortex. You have a liquefied cortex, and the heavy nucleus tends to settle down, which is seen like this. And then what you have is a heavy brown nucleus sinks to the bottom. Okay, so now there would be no confusion. So let's quickly revise what do we get to see. So what happens is, when we talk of a cataract, so there are, what are the changes that let's see. So when we talk of cataract per se, when we talk of cataract, please note there are 2 types. There is a senile cataract, where when we talk of more than 50 years of age, and then there is a pre-senile cataract, which is occurring less than 50 years of age. So when we talk of senile cataract, there is immature senile cataract, when you get the iris shadow, when only few fibers are opacified, and when this process of opacification is complete. When this process of opacification is complete, so what do you get is, you get a pearly white nucleus. You get a pearly white nucleus. So this pearly white nucleus, which is seen in the pupillary area, is actually called as the mature cataract. So here we call it as mature cataract. So after this stage, now the process of degeneration further begins. By this, I mean to say it enters the stage of hyper mature cataract. So now what happens is, when we talk of a hyper mature cataract, if the hyper mature cataract, there is a liquefied cortex, as I told you. So when you have a liquefied cortex with the nucleus being settled here, with this being the nucleus, this is called as the Morganian cataract. This is the Morganian cataract. Whereas when you have the liquefied cortex leaks, so then you end up in a picture where you have a corrugated anterior capsule plus calcific deposits. And this is the stage where what you call it as the hypermature sclerotic cataract. So now there should be no confusion. Okay, let's quickly revise with the image. So when we talk of the first stage, we have something like this, which is the part of immature senile cataract. So immature senile cataract can be nuclear cataract, it can be cortical, or it can be posterior subcapsular. So basically when we talk, we begin with something like this. From here it goes to this stage when it becomes totally opaque. Once it becomes totally opaque, we land up with a pearly white nucleus, which is called as a mature cataract. So from here, the process of degeneration begins. It might go to hypermature sclerotic cataract, or it can result in a Morganian cataract. So Morganian cataract, you have a liquefied cortex with the nucleus being settled down, is the Morganian cataract. If possible, could you please take expected questions for UPSC too? Well, I didn't get your point. Sorry. By UPSC, what do you mean? This class is basically for FMG, okay? And then you lead up to hypermature, right? So this is all about cataract. So let's see. Now in this image, you have to tell me, identify this procedure. What procedure is being done here? Which procedure is being done here? What is the answer? Tell me. Is it goniotomy? Is it gonioscopy? Is it laser PI? Or is it keratometry? Tell me, what is your answer? Anybody? What is being done here? So what you have is there's something on the eye. You can see here what is being done here. What is the answer? Tell me. Is it goniotomy? Is it gonioscopy? Is it laser PI? Or is it keratometry? Okay, so I have the answers as gonioscopy, keratometry. Anybody else who wants to attempt this? Well, what is keratometry? Keratometry is the process of measuring the radius of curvature, right? So how do you measure the radius of curvature? There can be manual keratometers or there can be automated keratometers. Here, what is being done here is, if you see this process, there's a lens which is kept on the eye and the patient is in supine position. So let's see. So what do you see in this image? What we get to see is the patient is in a supine position with a lens on the eye. Now, any changes in the answer? Well, what is being done here is gonioscopy. What is being done here is gonioscopy. And what is gonioscopy? Gonioscopy is the process of what is gonioscopy. So let's see. So what is gonioscopy? Gonioscopy is the process to visualize the angle. It is the process to visualize the angle. So why do we need a thing to visualize the angle, and what is that thing that we require? So we require extra lenses to visualize the angle. Why? Because the light which is coming from the angle of the eye, which is formed by the cornea, the junction of the cornea and the iris, is the angle. So the light which is coming from this, the angle of incidence is more than the critical angle. And what is the critical angle in gonioscopy? Why do we need a gonioscopy? So what is that critical? What is the value of the critical angle? The value of the critical angle is 46 degrees. Is 46 degree. So the angle of incidence is more than 46 degree. Hence it undergoes total internal reflection. It undergoes total internal reflection. To overcome this problem, we use lenses. So now you have to tell me what kind of gonioscopy is being done here. Now tell me, what kind of gonioscopy is being done here? Is it a direct gonioscopy or is it an indirect gonioscopy? Tell me. I want it in the chat box. What is being done here? Again, we have a free special class which is present on gonioscopy, which is a recorded free special class on gonioscopy at the Unacademy platform. So all those who want to know more about gonioscopy can refer to this session, which is again a 1 hour session. It's a free special class on gonioscopy. So my question is absolutely right, Stardust. What is being done here? We are doing a direct gonioscopy. So we all know that when we talk of gonioscopy, it is of two types. It is predominantly of two types. One is a direct gonioscopy and the other is a indirect gonioscopy. So what is a direct gonioscopy? The lenses that we use for performing the direct gonioscopy are called as gonio lens, and the ones which we use for indirect are called as gonio prisms. Gonio prisms because they use either mirrors or prisms to visualize the angle, right? Another important thing that when we talk of direct gonioscopy, the hint to know is the patient is in a supine position, and what we get to see is we get a virtual what we get is we get an erect image of the angle. But when we talk of indirect gonioscopy, here the patient is in a sitting position. And what we have is, we have a mirror image of opposite angle. What we have is a mirror image of opposite angle. Here the patient is sitting, and what we get to see is we get to see the opposite angle, right? So direct gonio lenses, direct gonioscopy, what are the lenses which are available? Again, that is of importance when we talk of the direct. What are the examples of direct gonio lens? We all know the mnemonic, and the mnemonic is ALS, BLS courses we do. So it is BLS2 right kidney. It is BLS2 right kidney. By that we mean it is Barkan lens, it is Leyden, Swan Jacob, Thorpe's, Richardson Sheffer, and Coipes lens. And now you have to tell me which lens is being used is in this image. Out of these direct lenses, which lens is being used in this image? Tell me, which lens is being used here? Any guesses? Which lens is being used here? This image is using the Coipes lens. It is using Coipes lens. right? So now you know which are the direct gonio lenses. Let's quickly revise. So by B, we mean the B is the Barkan or Hoskins-Barkan lens. L is the Leiden lens. In that session, I have the images of all the lenses and their particular things to identify. So you can actually refer to that. By S, we have Swan-Jacob. T is the Thorpe lens. R is the Richardson-Scheffer lens. And K is the Coipes lens. Okay, so these are the direct gonio lenses. Now you have to tell me, so the indirect lenses can be corneal or they can be scleral. For example, the lenses, the ones which are used for indirect are the, we call it as the Goldman lenses. And the Goldman lenses are shown below. So now you have to tell me what is image A and what is image B. Okay. So now the image A. The image A is basically a Goldman. Is it single mirror or a double mirror or a triple mirror? It is single mirror, double mirror, triple mirror or four mirror lens. Image A, tell me. It is one mirror or three mirrors? What is image A? One mirror or three mirror? Tell me. Yes, so it is a Goldman. See, this is a single mirror. It is a Goldman single mirror lens. So this one is a Goldman single mirror lens. And the important question here is, what is the angulation of this mirror? So the angulation, you should remember, the angulation is 62 degrees. The angulation is 62 degrees. And when we come to this one here, so which lens is this? This is the Goldman 1, 2, and 3. So this is the Goldman 3 mirror lens. And these are the indirect gonio lenses or gonio prisms. Now, out of these, which lens is used for gonioscopy? You have to tell me. Which lens is used for gonioscopy out of option 1, 2, and 3? Which lens? Is it lens number 1, 2, or 3? Which lens is used for, and there's another one in the center. So which lens is used for gonioscope? This is the central lens. Which lens is used for gonioscopy? It is the prism mirror 1. Mirror 1 is used for gonioscopy. And what is the angulation of mirror 1? The angulation of mirror 1 is 59 degrees. Right? So these two things you should know. The angulation of the single mirror, which is 62 degree, and the angulation of the gonioscopic mirror in Goldman 3 mirror lens, which is 59 degree. So this is the smallest mirror, mirror number 1. The smallest mirror, this one is used for gonioscopy. So this is a Goldman 3 mirror lens, right? Okay, now you have to sequence them. These are basically the layers of cornea. You have to sequence them from out to in. Okay, sequence them from out to in. Now tell me. So you have to tell me, is it A, B, C, D? Is it A, D, C, B? How is it? So which is the outermost layer to the innermost layer? Come on, tell me. Okay, B, D, C, A. Perfect. Absolutely right. So let's see the answer. The answer is basically the Bowman's layer. I told you what comes first. B comes first or D comes first. So it is the superficial most is the epithelium. Below the epithelium comes the Bowman's layer. Comes the Bowman's layer, which is option number B. Below the Bowman's layer is the stroma. This stroma forms 90% of the thickness of cornea. So below stroma is the Dua's layer. This has been recently discovered in 2013 by Dr. Harminder Dua. So what we have is Dua's layer, which is option number D. Then after Dua's layer, we have the Descemet's membrane. So which is option number C. And last but not the least, we have endothelium. So last but not the least, we have endothelium. So most metabolizing layers are two. It is the epithelium and endothelium. So this is the sequence of anatomic layers of the cornea. Clear? Okay, so this is what I have told you. So what we have is the superficial most as the epithelium. Then we have the Bowman's layer, which is this. 90% of the thickness is the stroma. Then the one in yellow is the Dua's layer. The one in green is the Descemet's membrane. And last, the innermost is the endothelium. And inside the endothelium, then we land up in the AC, which is anterior chamber, which is filled with aqueous humor. All right. So now you have to identify these signs. So let's start with image A, B, and C. So what is image A? Tell me. I have to simplify it. I have also written upper and lower eyelid retraction. So tell me, what do you call this sign as? Which sign is this? Upper and lower eyelid retraction. Where, which disease do you get it, and which is the sign? All right, so this is the most common and the earliest sign seen in, tell me, Graves' disease, or you also call this Graves ophthalmopathy, or it is called as thyroid eye disease, which is TED, or called as Graves ophthalmopathy. Very good. That is right. So one part you have answered. Now tell me, which sign is this? What do you call this sign? Eyelid, upper and lower eyelid retraction, and this is called as the Dalrymple's sign. This is called as Dalrymple's sign. So this is the most common and the earliest sign to be seen in Graves' disease or in thyroid eye disease. Then what sign is this? Lid lag on down gaze is what you call that. I think no, nobody has answered. So which sign is this? Lid lag on down gaze. What do you call it? It's not exophthalmos. Exophthalmos. What is exophthalmos? No, it is not exophthalmos. Yes, it is called as, very good. It is called as Von Graeff's sign. Very good. And what is this? What do you say? Get to see here? There's inability to close the lids completely. So what do you call this sign as? Keratoconus? No, it is not keratoconus. Inability to close the eyes completely is, what do you call it? What do you call it? Is lagophthalmos. So what is lagophthalmos? Lagophthalmos is the inability to close the lids completely. is leg of thalamus. Yes, very good. All right. So this is leg of thalamus. So which disease do we get it? We get it in thyroid eye disease or Graves of thalamopathy. And the most common, the earliest sign is Dalrymple's sign. What other signs do we get? We have von Graff's sign. We have leg of thalamus. We have eggs of thalamus. Most common cause of unilateral or bilateral proptosis. Most common cause of eyelid retraction in adults is thyroid eye disease, right? Von Graff's sign is seen in cases of thyroid eye disease. In keratoconus, it is not von Graff's sign. In keratoconus, the sign that you're trying to mention here is the Munson sign. That is the deviation of the lower lid when you try to look inferiorly. If I have got you right, that is what you mean to ask, right? So what you were saying is von Graff's, that is lid lag on down gaze, that is seen in cases of thyroid eye disease, right? And pseudo von Graff's sign is a aberrant regeneration of third nerve palsy. And in keratoconus, what you're talking is what you get is the Munson sign. So what is Munson sign? It is the lower lid deviation when you look down or when you look inferiorly. Is that clear? Great. All right. So identify this image. So let's see, what do we get in this image? So as I always say, whenever you get an image, please try to understand what is the picture saying. You will never have the same picture in the exam. But if you know what the picture is talking about, what is the main sign that you have to pick up, you will not miss it. So now here, what do we get to see? Let's see. So what we see in this picture is there are hemorrhages. Right? You can see these hemorrhages which are localized. Right? These are superficial hemorrhages. And what do you call the superficial hemorrhages as? Flame-shaped hemorrhages. Then you have these spots. What are these called as? These are called as, anybody? Yes, absolutely. These are the cotton wool spots, or are also called as soft exudates. So what are we dealing with? Anybody now? So you have hemorrhages in one quadrant. Then what you have is soft exudates. Then if you can see clearly, if you try to look here, what is happening? There is an occlusion which is happening at the AV crossing. See here. So this is the artery which is going and it is being compressed by a vein. So what is it? Diabetic retinopathy. Diabetic retinopathy will have hemorrhages, will have microaneurysms in the quadrants, which is mild, moderate, severe. But this one with venous changes, with occurring at the AV crossing, occurring at the level of AV crossing is what? This is branch retinal vein occlusion. So what is it? It is a branch retinal vein occlusion. Why is it a BRVO and not this? So what is the comparison? How will you differentiate between this image and this image? So what are the differences? So if we try to write down the differences, so what do we get to see in this image? We have hemorrhages in all four quadrants. Right? So hemorrhages in all four quadrants and a localized quadrantic hemorrhage with cotton wool spots with occurring at the AV crossing is BRVO. But when you have hemorrhages in all the four quadrants is classically called as a, which appearance is it called? Anybody? I have written half of it. Anyways, anyone who wants to attempt, what do you call the image as? So what does this look like? What does this image look like? What is it called? Yes, absolutely. It is called as a tomato splash appearance. Tomato splash appearance. So what condition is this? So what is the diagnosis? What condition are we dealing with? What is this? Which disease do you get a tomato splash appearance? It is a central retinal vein occlusion, CRVO. So CRVO is a central retinal vein occlusion. And what is the site of occlusion here? It is just at or posterior to lamina cribrosa. Right? So now another important thing that you have to tell me, one is CRVO, what you get is the site. It has a tomato splash appearance. It is of two types, ischemic and non-ischemic. And when we talk of the complications, what is the fancy name which is given to one of the complications that we encounter here? So I will tell you, when we deal with ischemic CRVO, there is neovascularization. So the glaucoma that we end up with is called as, what kind of a glaucoma is it? Very good. What kind of a glaucoma? Yes, it is a 100-day or a 90-day glaucoma. 90 days or 100 days glaucoma. So the significance here is, why are we trying to mention the days? We're just trying to mention the days to cover the time duration that is required for the glaucoma to happen. So there will be ischemia, there will be VEGF increase, there will be neovascularization, and once the neovascularization goes into the angle, then it results in glaucoma, which is called as a 90 days or a 100-day glaucoma. Right? So this is CRVO. CRVO should know what is the site, what is the appearance called, and what is the complication. Glaucoma specifically called as 90 days or 100 days glaucoma. Okay. Then we move on to the next. So which of the following is the yoke muscle of right lateral rectus? The options that we have are superior oblique, right inferior oblique, right medial rectus, or left medial rectus. Okay, Lavanya says it's D. Anybody else who wants to attempt? Anyone else? Anybody else who wants to attempt? So what you have to remember here is, what do you mean by yoke muscle? So here the confusion point is two words. One is, what is synergist, and what is yoke muscle? Now please make it clear that whenever we do a movement, so whenever we do a movement, there are certain group of muscles which are acting together. There is a pair of muscles which is acting together. So when that pair is in the same eye, right? So I'll write it here, pair in same eye. So S for same, S for synergist is the synergist muscle. For example, when we want to elevate the eye, so what are the muscles which help us in elevation? They are, suppose we're talking about right eye, so it is right superior rectus and right inferior oblique. So the pair, the group, the couple of muscles which are from the same eye are called as the synergist. Okay, S for synergist and S for same. But when this pair is from both the eyes, that means one from each eye, that is called as the yoke muscle. Clear? Now there should be no confusion. S for synergist, S for same. So one in each eye is the yoke muscle. One in each eye is the yoke muscle. For example, the question says right lateral rectus. So when I have to look here, my right lateral rectus will move outside and my left medial rectus will also move towards this direction. So the right lateral rectus has abduction and left eye has adduction. So right lateral rectus causing abduction and my left medial rectus causing adduction is when is the is the yoke muscle to the right lateral rectus. So one option is when you're talking of yoke muscle and it says right, so the automatically it says the eye has to be left. The answer has to be left. Now you get it? When it says yoke muscle and when it says right, so that automatically means it has to be from the opposite eye. We have to come down to left eye. So which out of the four options is left? Only one, that is left medial rectus. So even if you did not know the answer correctly, so applying your mind, you get to the answer, right? This is how you have to solve. You might not know all the answers. You might be confused. You might be at a panic point in the exam, but just relax. So if you use your common sense, you apply what you know smartly, intelligently. That is the reason I tell you, have a good sleep before you attempt your exam. Because before you write your exam, all you want is a fresh mind, right? So now is that point clear? So when you're talking of right lateral rectus, I'm talking about the yoke muscle. It is from the opposite eye. Is that clear? Now no confusion. Can we move ahead? Is that okay? All right. So now identify this instrument. Which instrument is this? So what you have is, which instrument is this? This is a handle. This is from where you see, and these are a set of lenses which are rotating. Okay, so which instrument is this? Tell me. Anyone? So I will write and you also write. Let's see who writes first. So this is called as a direct ophthalmoscope. Absolutely. So just not ophthalmoscope, it's a direct ophthalmoscope. If this is direct, which instrument is this? Tell me. So which instrument is this? This is indirect ophthalmoscope. Absolutely. So this is indirect ophthalmoscope. Now you tell me, out of the two, direct and indirect, which ophthalmoscope uses the condensing lens? In which ophthalmoscope? Is it direct or is it indirect? Do we use a condensing lens? Tell me, where do you use a condensing lens? Indirect ophthalmoscope, right? So this is a condensing lens. right? So direct and indirect ophthalmoscope. That's very, very important. So when we talk of direct ophthalmoscopy, what we are talking is the working distance is closer to the patient. It is close to the patient. The image that is formed is virtual and erect. It is more magnified, hence it covers lesser area. Because the magnification is more, so the area examined is less. The magnification is to the tune of 15 times, and we cover an area up to 2 disc diopters. That is maximum up to the equator. Whereas when we talk of an indirect ophthalmoscope, please remember it uses a condensing lens. It uses a condensing lens. Right? You work at an arm's length where the lens is placed. It gives you real and inverted image. The magnification is lesser, hence the area covered is more. Do you get that? The magnification is 3 times, and hence the area covered is 9 disc diopters. So here it uses a bright source of light. Since the source of light is brighter, hence you can use it, or it can be used to visualize in hazy media. It is used to visualize in hazy media also. And also in indirect, you're seeing from both the eyes. So since there is binocularity, there is stereopsis. There is stereopsis. Right? So here it is a brighter light, which can be seen in hazy media. It gives you stereopsis, and here you can have a retinal evaluation up till the periphery with indentation. That is what exactly I told you. What we are doing is, with the direct ophthalmoscope, the magnification is larger, the area covered is smaller, right? And what you can visualize is up till the equator. But when we talk of indirect, it has a stronger light which can be used in hazy media. We do a binocular evaluation. Since binocularity comes into play, so it gives you that stereopsis. The magnification is lesser, hence more area is covered, and you can visualize up till the periphery, and even with indentation is possible. So it gives you a real and inverted image. It gives you a real inverted image. So this is the last question of the session today. So male with a history of liver disease. Male with a history of liver disease developed a cataract as shown in the image. Which substance is deposited in cornea? So now you have to tell me, what do you get to see in image A? What is image A and what is image B? So what do you see in image A? And if you want to see clearly, I will just increase the focus. Now you want to see here. What do you get to see here? A golden brown discoloration, a golden brown deposition of which substance? The answers that I have is A. Absolutely, it is right. But tell me, what do you call image A? What is the finding? What is the feature that you see in image A? What is it called? What is it called? You're absolutely right. What we are talking of is the Wilson's disease. What we are talking about is the Wilson's disease, or it is also called as hepatolenticular degeneration. So what sign is this? Image A. This is called as the KF ring, or it is called as the Kayser-Fleischer ring, which is seen because of the deposition of copper. Absolutely, the answer is copper. There is deposition of copper at the level of Descemet's membrane, at the level of Descemet's membrane of cornea. Similarly, this copper is also deposited in image B. And what kind of an image this image B is called? This is a cataract which you have with centrifugal extensions. So what kind of a cataract is this? This is called as sunflower cataract. Right? So these two are because of the deposition of copper. They are seen in Wilson's disease. They are seen in hepatolenticular degeneration. But the point to remember here is that both of these, both KF ring and sunflower cataract, do not impair vision. These do not impair vision. Is that okay? So they do not impair vision. It is because of the deposition of copper. And what is the drug of choice? The drug of choice is D-penicillamine or Triantine. The drug of choice is D-penicillamine. Also, the other drug that we use here is Triantine. So this is Wilson's disease, where you have deposition of copper at various levels. If it is at the level of cornea, it is seen as KF ring, which to begin with is seen superiorly and inferiorly, and then slowly it engulfs 360-degree. And if it is in the form of cataract, it is called as sunflower cataract. Right? So with that, I end my session and I say thank you with all the best. Thank you with all the best. The thing that I want to mention here is that I have covered Wilson's disease. Of all the topics that we have discussed today, there are certain topics which have already been covered, like Wilson's disease. So the ones which you should go and attend in the Unacademy app in free special classes is Wilson's disease, which is covered under INI CET special topics. So Wilson's disease is covered in details there. Then you have to read refractive errors. So refractive errors is another. These are all free special classes. And last but not the least, you have to read or you have to listen to the lecture on gonioscopy. Right? So all these are the free special classes which are available on the app itself. Right? These are the recorded lectures. Go attend them, revise these topics from there, follow your schedule, make a detailed schedule, follow them carefully, discipline yourself. The time is here. We can't rest now. I will put in the PDF of this lecture on my Telegram group, which is by the name of Dr. Bhumika I. So you will get the PDF of this session on that Telegram group in a while. Meanwhile, I wish you all the best. Any doubts, I'm happy to help. Take care. Follow your schedules. Thank you so much.